I hope we have last couple people coming in here. All right. Well, hello, everybody, and welcome to the latest Still COVIDing chat. Of course, I'm Kara Familia Hernandez Darling on Facebook, and tonight we have with us Dr. Robert Groysman, author of the Long COVID Handbooks. That's plural. There's multiple of them that talk about all sorts of interesting things. And tonight, the focus of Volume 3 is actually mitochondrial dysfunction. So today, that's what we're going to delve into. So thank you for being with us, Dr. Grossman. We appreciate you spending your time to share your knowledge with us.
Thank you, Kara. My pleasure.
Okay, so to get started, I thought we might just go over what I can talk about, which is the mitochondrial basics. I'm going to take us back to fifth grade science about the cell. And then when I'm done, Dr. Grossman can talk about long COVID and mitochondria, what he's seen in clinic, and what we can do about our mitochondria function or lack thereof when we have a COVID infection. So let me literally take you back to the Jello cell. Can everybody see the Jello cell? Can you give me a thumbs up
Very
if you can
cool.
see? Awesome. So, some of you guys might have done this when we were, like I said, it was about fifth grade for me when we started to learn about the parts of a cell. And we learned about the cytoplasm and we learned about the nucleus where all the DNA was. And one of these little organelles, and it's sort of hiding over here behind this little Golgi body, were the mitochondria. And you might remember that the mitochondria, what they told us so that we would remember what the mitochondria did, was that the mitochondria are the powerhouse of the cell. And here's actually a little bit better drawing. And you can see right here, this little organelle that has the little squiggly middle here. And that's the powerhouse of the cell. Mitochondria basically give us all of the energy that our body needs to function, whether it's to think a thought or to speak or to move a finger. You have to pay ATP, which is energy, and that energy is produced in your mitochondria. The mitochondria are little ATP factories. Fun fact that I didn't learn probably until much after fifth grade, way later, was that mitochondria are the reason we have to breathe. You know how you can go about 6 minutes without oxygen before you start getting brain damage? That's because after about 6 minutes, your mitochondria, which need oxygen to make that ATP, stop producing it. And the biggest energy user in your body is your nervous system and your brain. And so that's why brain damage occurs when you become hypoxic, is because these little mitochondria guys really need the oxygen to keep pumping out that ATP that fuels everything in our bodies. So how does that work? Well, basically it takes our bodies take what we eat through digestion. So they take fats, carbohydrates, and proteins, and they do a whole bunch of chemical transformations to what we eat. And that's why your gut's important. If your gut isn't in line, you can't, absorb these nutrients and digest them. That turns them all into something called acetyl-CoA, which then spins them into the mitochondria, into the citric acid cycle, and into the electron transport chain. And that electron transport chain is the battery factory. It's what makes the batteries. I call them the batteries of our body. ATP is the batteries of our body. So what we eat goes on through a bunch of chemical transformations and becomes the batteries that make our cells go, make our muscles go, make my mouth run like it is right now. How does it do that? And I just want to sort of give you this broad overview because I know when we talk about how COVID stops the energy production, it's sort of good to understand how the energy production happens in the first place. So mitochondria actually are curious little organelles. They have actually two membranes, an inner membrane and an outer membrane. And the reason why they have those membranes is that this little battery factory that we just talked about, this electron transport chain, has to sit right on the edge of that second membrane. And the reason why it sits right on the edge of that second membrane is the way this factory works is sort of like a generator. There's something called the ATP synthase that spins like a generator and pops those batteries out. And the way you get that generator to spin is by you taking your foods into your acetyl-CoA, and then that makes electricity that runs through pumps that pump a lot of protons up into the space between the two membranes. And if you ever tried to put two ends of the like ends of a magnet together, you know how they push apart? all of these protons that get pushed up here hate being stuck in a small space. And there's only one way out, and that's through this generator over here, through this ATP synthase, which sort of looks like this. So I got a bunch of crowded protons in there, and they're pushing against each other because they all have the same charge. They go down and out through the little hole in the synthase that spins the generator, and that's what makes the ATP. And so that's why we have to have two membranes in the mitochondria. And so there's a space for that gradient. Then the protons come down through the gradient and make the ATP. And then the ATP is utilized by our cells literally again for everything. So definitely we'll take questions afterwards, but I just wanted to sort of give you like this brief, big view of what the mitochondria are doing for you. And so now we can talk about like how COVID interferes with this and what are some of the downstream effects when you interfere with this process. So Dr. Groysman, do you want to talk a little bit about what happens?
Sure. So we're going to talk about COVID first, as what it does when the virus gets into your body. So the purpose of the virus is to reproduce. It wants to make more of itself. It doesn't consume anything. It doesn't release anything. It just wants to make more of itself and be released and infect something else. So when it gets into our cells, it gets in through a receptor called the ACE2 receptor. And this is a receptor that normally is used for kidney and blood pressure regulation. And it actually acts like an enzyme. It turns I guess a hormone called angiotensin into angiotensin 2. Um, So it kind of works two different ways. When it gets into the cell, it gets in through by contacting the spike protein, touches and basically docks into the ACE2 receptor, and the whole complex is brought into the cell, and it sits in the lysosome for a little bit. And normally the lysosome would break it down, break the virus down, break the RNA down, but the virus has some defenses against it, and the mRNA escapes. And it makes its way to the ribosomes and starts replicating, basically making more copies of itself using the proteins inside that are coded inside the mRNA. What it also does is it doesn't want to get caught. So we have what's called an innate immune system. Now, this one is non-specific. It doesn't care what the pathogen is, bacteria, virus, fungus, whatever. Um, And this is our first line of defense. And if something doesn't look right, like for instance, having mRNA floating around in the cytoplasm of a cell, that usually starts a process to attack and prepare for a viral attack. However, COVID is a little smart. And what it does is it attacks the mitochondria. Mitochondria are really the first ones to release a signal to start this innate immune system going. Okay. So what it does is it disables the system. And this is meant not to destroy your mitochondria, but to basically allow it to replicate, which is its only and one goal. Not to make you sick, not to cause trouble, but just to make more of itself. So in the process of disabling this mitochondria, it causes some damage to it. Now, mitochondria are kind of weird little organelles. For one thing, they are kind of their worst enemy. They need the perfect amount of oxygen, perfect concentration. Too much, and you have oxidative stress. Too little, and you have oxidative stress. They also make their own oxidative stress just from being inefficient because they're not perfect. They're biological machines, just like your engine makes heat, right? That's why you need the radiator, and it makes waste. That's why you have the muffler and the tailpipe. Your mitochondria do the same thing. So if you don't have the perfect environment, they don't function well. So what these viral proteins do is not only do they turn off the signaling from the mitochondria to start the innate immune system, but they also stop energy production. And the way they do this is they break that proton gradient that Kara was telling you about. So when they go in, they disrupt the system so that gradient disappears. And now your mitochondria can't generate ATP as well or not at all. That's kind of one method. Um, they also damage the membranes, and, and that's because these proteins insert themselves into the mitochondria membrane. Again, not for the purpose of causing destruction. The problem, there's no evil intent here. This is just the virus trying to survive, and it's doing what it has to do to make more of itself. Um, so one of the other problems with these viral proteins is they're also damage lysosomes. Again, for the purposes of being able to escape and be able to replicate and make more of themselves. So lysosomes also help turn over mitochondria. That is, when the mitochondria is damaged, normally a lysosome comes along and it's kind of like a garbage disposal system. It comes in, it brings the mitochondria into the lysosome. It secretes some acid and breaks it down, just like a stomach, and it uses those components to make something new, maybe a new mitochondria. Uh,
Recycling.
yeah, it's basically recycling, exactly. So, but what happens if the mitochondria gets in there and it can't break it down? Well, now you don't have the raw material to make more mitochondria, but you also have a full garbage bag that's filling up more and more with stuff that you can't break down. So this is sort of the problem that happens with COVID and what leads to long COVID. So normally, there's many viruses that damage mitochondria, flu being one of them, influenza. It comes in, it damages mitochondria using different proteins, but it doesn't damage the repair system. So about 2 weeks after you recover from the flu, guess what? Your mitochondria are completely recycled and they're back to normal, and you feel great. You don't have long COVID. You don't have long flu. But when the system is damaged, the damaged mitochondria have no way to repair themselves, have no way to recycle, and you basically have a lot of garbage stuck in these lysosomes inside your cells. So that's the gist of kind of how COVID causes the mitochondrial dysfunction. And what's important to know is this is not a primary mitochondrial disorder. What I mean is not every single mitochondria in your body is damaged. There are many children that have a genetic defect in the mitochondria, and every single mitochondria in their body is damaged. Okay. Yes, you can still treat it, but you can't replace them with healthy mitochondria because it's a genetic problem. COVID is not like this. It's a secondary problem. So some mitochondria in some of your cells, in some of your organs are damaged, but not every single cell and organ is going to be damaged. Still, it's enough to cause oxidative stress in a certain area, which causes damage in the surrounding areas, and then it multiplies. Because as I said, when you have damaged mitochondria, they're their own worst enemy, and it's like blocking the smokestack of a factory. You're going to choke yourself out. The workers are going to start coughing and hacking and have to leave the factory. That's kind of what happens, and that smoke spreads to other areas and it damages close cells that are next to it and so forth. So it's important to address mitochondrial dysfunction. About 80% of people with long COVID have mitochondrial damage or significant mitochondrial damage um, to be
And
causing long COVID.
Dr. Groysman, is it true? Because this is what I've heard that as oxidative stress increases, so as that smoke increases, then your body will naturally downregulate mitochondrial replication because it's trying to say, oh, I've got too much oxidative stress, I've got too much smoke. So it doesn't do the normal replicative process that it would do to actually replace those mitochondria as well.
Well, yes, but you can't replace them because you have no room. You
Mm-hmm.
have basically the cell filled with a huge bag of garbage, pieces of mitochondria that are damaged, that are partly digested, and they just sit there. So there's very little room to actually create new mitochondria.
Right, but my point is your cell wouldn't do it anyway if oxidative
Correct.
stress levels were high, because that
Correct.
feedback mechanism too would be like, whoa, no more smoke, you know?
Correct. Yes. So we're talking about just your normal body processes. We're not talking about anything external like smog or smoking or anything else
Mhm.
that would introduce extra oxidative stress into your body. We're just talking about the regular stuff that's inside your body that's causing all these problems for you right now. So the the way I work with people with mitochondrial damage is it has to be very slow. Okay, I know there's some docs that like to do rapamycin or intermittent fasting or even exercise. All those will cause significant mitophagy, but would also stress the system quite a bit. So I push those activities or those therapies further out when their bodies are more ready for that kind of mitophagy. I find that a lot of patients early on, especially if they've had long COVID for 3 to 5 years, have accumulated a lot of damage. And their body is not able to tolerate mitophagy, which is basically the recycling of the mitochondria. And if you try to push the system too hard, it will backfire. And the backfire is that the system will burst. In other words, the lysosome will pop and it will release all that wonderful garbage into the cytoplasm. And there's actually a sensor inside your cytoplasm called cGAS, which is a protein that activates part of the innate immune system, and it reacts to double-stranded DNA. And luckily for us, mitochondria have their own double-stranded DNA.
Right. Yep.
So all of a sudden, you have this huge influx of double-stranded DNA from the damaged mitochondria, and they set off inflammation, and the cell either dies or bursts, or both. And then it releases it into the near vicinity for this to replicate over and over again. So it's a very inflammatory process. So I try not to push mitophagy in the beginning for that reason. Now, some people, they've, for some reason, escaped this, and it's about 1 in 10, maybe 10%. And they're able to do intermittent fasting and they're able to do rapamycin. And if they already tried it and proved that they can tolerate it, sure, we just go along with that. But if I'm starting out fresh with somebody, then we really have to be careful not to push mitophagy too hard. Um,
And what about the deficit? Because we all know that like COVID also affects the GI tract, right? Like one of the things that makes COVID so unique is all the places in your body you have these ACE receptors. And so if we think back to sort of my analogy of what comes in and what goes out, if your digestion is impaired and you're not getting adequate fats, proteins, and carbohydrates into the system because of digestive impairment by COVID, then how are you going to be able to fix your mitochondria? So do you do that concurrently? Do you like work on digestion at the same time you're working on your mitofunction, or do you do like digestion first and then mito, or how do you see the relationship between
sure.
the gut and mito?
I often do them concurrently. What's interesting about mitochondria is that whole process you described of a fuel molecule mainly fat and carbohydrate, your body prefers not to use amino acids or proteins for fuel if it doesn't have to. It'd rather use it for building material.
Right.
But yes, you're right. It could be used for fuel if it needs to.
Hmm.
But all of those all of those fuel molecules, they get converted multiple times. Part of the Krebs cycle or the citric acid cycle that you showed is essentially taking off electrons from basically taking a high energy fuel molecule, carbon skeleton, and stripping off electrons piece by piece. That's where the NAD comes in. That's where, but basically it's an electron carrier. So the whole
Yep.
point is to strip off as all the electrons before you get basically carbon dioxide.
Right. You're right.
So
Did you see my little electron, like my little electrical like current running through there? Did you see that?
no, I didn't see it.
I'm going to show you because you have to stop and appreciate this electric current, okay? Do you see that? See?
Not yet.
It's right there. See, this is the little electrons, the little electrical
Oh,
current.
yes,
It's like
yes. I'm
lightning
sorry.
bolts. See that? So here's your NADH and your
Yes,
FAD. See this little
yes.
look?
FAD. Yes.
Yes, see right there? Zoom right through there. That's what Dr. Grossman is talking about. And I found a lightning bolt to make the electric current out
So,
of.
so these electrons are used to pump the protons out
Right.
against the gradient and basically force them together. So that's why we need the electrons, and oxygen actually accepts the last step for the. That's why we need the oxygen to
Yep.
accept that last bit of electron.
Electron as it comes out. Otherwise, this will stop spinning.
Correct. So that gradient has to be maintained for that to work. So what's interesting is a lot of these enzymes,
Mhm.
including in the electron transport chain complexes, rely on very specific trace elements.
Yep.
We need magnesium, we need selenium, we need manganese, we need zinc, we need iron. Iron is very important for the
I think we
cytochrome.
have,
So yeah,
yes, some of these cofactors up here. Do you see? Here's
exactly.
Fe is iron. Here's reduced glutathione. I mean, glutathione. Here's magnesium. It has some of the cofactors up here in this cycle. Yeah, the cycle will stop without the cofactors.
And yes, B vitamins are extremely important. One, two, three, five, um, 5, 12, and six and 12 are also part of the methylation thing, um, but B3, 1, 2, and 3 are kind of the most important ones for the Krebs cycle. You need B12 and B6 for the beta oxidation part. Um, so
Magnesium and
yes,
B2. Yep.
yes.
Yeah, and
So
you can't make acetyl CoA from pyruvic acid without folate.
correct. So yes, you obviously need to be able to absorb all these vitamins and trace elements. And yes, iron is a big one. People have trouble absorbing iron, and some people have trouble absorbing B12. Some people
Yep.
have trouble absorbing B1. Um, so yes, you do have to address all the cofactors and the trace minerals that are involved in the function of mitochondria, not just the building material. You also need all the pieces, basically all the workers that are inside the factory. Otherwise, it's not going to work. So yes, you do need to address both gut and mitochondria. And yes,
Concurrently.
yes.
So to give our audience sort of a step by step, so in your practice, you don't want to push, too much mitochondrial replication or recycling yet because that makes people sick. And so as they tolerate it, what do you do? Like what's your step by step like thought process when you're trying to help the mitochondria recover post COVID?
So the way my method works is it used to be a four-step process, but I realized something and I made it into a two-step process because I realized that pretty much everything that causes mitophagy also causes biogenesis, which is making new mitochondria. So it didn't
Mhm.
make sense to separate those steps. So I prepare the field. Okay. I say to people, winter is over. You're coming out into your garden and you look there and there's leaves all over and there's weeds and there's other stuff there that, you can't just, pop the seeds in and go. You have to prepare the soil. And that's what step one does. Step one is antioxidants and support. So I do this for several weeks first to lower your oxidative stress, the reactive oxygen species overall in your body. Because if you start early, it's not going to really do much. And usually by the third or fourth week, I start just a very short run, a pulse of mitophagy, very gentle, just for a few days. That's it. And as symptoms improve, as fatigue improves, as PEM improves,
And what do you use for that short course?
I mean, I have a lot of different selections. I mean, Urolithin A is one, but there's several. I prefer to use supplements over rapamycin or metformin because I feel that they're too strong. And same thing, same reason for intermittent fasting. I mean, I used to use it early on, but I realized people were getting sick or not feeling well. And it took me a little while to figure out why. And that was because the mitophagy was being pushed too hard for what it was able to handle at that point. So yes, you can do that later on, maybe 3 or 4 months down the line. But in the beginning, you really don't want to blast, that system into making and removing damaged mitochondria. Um, Nicotinamide riboside, for instance, can be used. Um, but like I said, there's several, spermidine. There's several different agents. I don't use too many. I mean, I'm not putting people on like 8 different mitophagy agents. Okay, so I'll choose between two and three to start with. If I think that they're really fragile, I'll only put them on one. Um,
You ever use PQQ?
yes, PQQ does not work on mitophagy. It mostly works on biogenesis.
Mhm.
It's actually the only one that is really kind of more for biogenesis versus mitophagy. But we have to first get rid of the garbage.
Right.
If you start, so I see people on PQQ, 30 days every month, every day. And the problem is you haven't removed the garbage and you're basically crowding that cell until it bursts.
Right.
So you're not doing anybody any favors.
But the good news is that stuff like NAC, which is an antioxidant, also is a detox factor and a sulfur donor. So it can sort of help you get rid of waste and, tone down your oxidative stress all at once while you're preparing the field.
Yes, so that's actually part of step one.
Mhm.
NAC is one. So I have a big list, but I choose which ones I want to put people on. They're not on every single supplement or medication. I decide on what they need to be on depending on their unique circumstances. So, but yes, I do use NAC as a glutathione precursor. Um,
So, so again, some of the things that running around the groups and listening to what people were talking about when I said, hey, let's go do this mito talk, right? Like come listen to this mito talk, was that oh, this is all well and good, and we are interested in the science and how all this stuff works, but like what can I do at home? Like what can I do that I don't have to like go to a doctor's visit right now to do, or that I don't have to pay a lot of money for testing for? What are some simple things that I can do to get me started, and then maybe I might have the energy to go to my doctor's appointment.
sure. So the number one thing is antioxidants. I mean, antioxidants are going to be number one. Whenever you have a chronic illness, your mitochondria are not going to be working at top efficiency, which means that you're going to have a higher level of oxidative stress than the average person who doesn't have a chronic illness. And it doesn't matter if it's diabetes, it doesn't matter if it's Parkinson's. The point is if you have something that's ongoing, it's causing your mitochondria to stress out. They don't deal well with stress. They just don't. And they produce more smoke.
Mm-hmm.
I mean, that's just it. So our first step is to again remove themselves from being their own enemy, which is reducing oxidative stress because it's a crazy positive feedback loop. The more they're exposed to oxidative stress, the more they make oxidative stress, and
Mm-hmm.
it's kind of it can run away,
Mm-hmm.
that whole
It's that whole
process.
inflammatory feedback loop, right? That ends in apoptosis that you
Right.
don't want to be in.
Well, sometimes it doesn't even end apoptosis. Sometimes it ends in inflammatory cell destruction, which is worse.
Right.
Apoptosis doesn't cause surrounding damage. That's actually, if we're going to have a cell destroyed, I'd rather have it go through apoptosis and not involve its neighbors. But these cells are violent. I mean, when they explode, I mean, they cause surrounding damage. They release all these inflammatory factors into the surrounding tissue and cause other cells to be damaged and undergo the same process.
So, for all of you guys listening at home, the first thing that you would do to help restore your mitofunction with long COVID is start taking some antioxidants. And of course, you would work with your own healthcare provider. Dr. Groysman's not giving medical advice today, nor am I. But there are, common antioxidants that are readily available over the counter. And you can sort of play with which one works best for you. But there are things like vitamin C, CoQ10. We already talked a little bit about NAC. Huh?
Yes, yeah, I'm agreeing with
Yes.
you.
Okay. Like NAC, ECGC, you can even drink, purple grape juice because that's going to be rich in antioxidants. But anything to take to relieve that, that detox stress basically for the antioxidant for the oxidative stress that your mito are under. So I know a lot of people come and they really want to hear some of these things that they can do. The other thing that I also want to show you guys, and I think you and I have talked about this before, Dr. Groisman, is a little mito guide that you can. Now, I think the best thing to do is go to a professional like Dr. Groisman or come to one of our clinics and let somebody talk to you about mitofunction and look at your specific case, run the specific test, tailor it. But again, I know that like again for energy, for spoons, for time constraints, for money, that's not always feasible to go right away. I mean, we wish we had a Dr. Groisman on every corner, right? But as of yet, we still don't have that. You got to go to Texas. So so here is my favorite, just layperson. Well, I say layperson. It is an article from PubMed, but here's my favorite sort of mito guide. And this is written. Can you guys see this? It's an article that was written for those kids Dr. Groisman talked about that have mitochondrial damage in every cell. But it's applicable to people who have mitochondrial damage from long COVID, or medicines can damage your mitochondria. There's other mechanisms by which your mitochondria can get damaged. And so if you find this article, and it's easily available by Google, and you scroll down through the article, you don't have to read everything in it, but there's a nice little table right here in the middle of this article, which I really like because it tells you what agents you would use to treat mitochondrial function, and it tells you what they're doing for you, and even tells you dosage. And these are all supplements that are available over the counter. Now, again, we don't recommend you go get all of these supplements and take them all at once. It's going to make you feel really bad, but you might pick one or two of the antioxidants, or you might pick, you can see here that N-acetylcysteine, or you can see Dr. Groisman talked about B12 being important to mitochondrial function, or zinc as a cofactor. You can actually, use this article and use this table to play with some of the mito supports and see what makes you feel better, or what you respond well to and what you don't respond well to. And as long as you stay between in these doses that are available, these are not dangerous substances for you to try at home on your own. That's why they're over the counter. So that's my little hidden tidbit for you
So,
guys. Go
so what
ahead.
I was going to add is there's a couple of antioxidants which can function as pro-oxidants. So in the right doses, they do what they're supposed to do, and basically act as antioxidants. Okay, and really antioxidants are just reduction agents.
Yep.
Um, so back to basic chemistry. But what's important to know is that several of them, like zinc, iron, and vitamin C, if you take huge omega doses of them, they will turn into pro-oxidants. In other words, they're good antioxidants, but if they run out of if you overwhelm the system with them, they can actually act as oxidants themselves and do counterintuitive to what you're trying to do.
So stick to the doses on the bottle. Don't drink the whole bottle.
Yes. I mean, most antioxidants don't do this, but those three can do that.
Yeah, and then something that I like that's sort of easy to do, that will give you extra sulfur, which again will help, push your glutathione production and help support your detox are Epsom salt baths. And it's pretty easy to do Epsom salt baths, even if you don't have a lot of energy. You got to get clean somehow. Or you can even use an Epsom salt cream if a bath is too many spoons. But Epsom salt baths you can absorb the sulfur cutaneously, and that can help, help with your detox and help you get rid of oxidative stress.
So Epsom salt is pretty much pure magnesium sulfate
Right.
that does absorb through the skin. It helps with muscle relaxation, but again, hot baths especially, could be a problem for those with POTS, can be a problem for those with MCAS or histamine flares. Heat can sometimes cause that to flare. If you could tolerate it, of course, go for it. Um, but yeah,
Yep, that's why I always mention the cream, because
yes.
for the people who can't tolerate the baths, or for the people who are heat sensitive. Now I don't get any commission for showing you you guys this link, but this Kirkman's original Epsom salt cream, if you rub that on your body, it works like an Epsom salt bath. And it can actually, help you get the benefits. A lot of people think that it's the magnesium that's relaxing to them, but we really find when we look at the different markers that the sulfur is what's actually super important in the magnesium sulfate combo there. And you can even use this for people that are sensitive to swimming in chlorine, which is here's another little life hack. If you're sensitive to swimming in chlorine, it's because that chlorine molecule sucks up all your sulfur, and stresses out your phenylsulfur transferase, and can cause some inflammation in your body, and almost like an allergic like response. And if you slather yourself up in this Epsom salt cream before you get in the pool, then the chlorine will bind with the sulfur in the Epsom salt instead of entering into your body so much. And a lot of people that are sensitive to chlorine can actually tolerate it if they use the slather method. And of course, if you're swimming in a public pool, don't tell them, because you're not supposed to have any lotions or creams on. But
I think they're gonna know.
if they're looking that close, it's on them.
Yes. Um, so you mentioned mitochondria and nerves. So mitochondria are the number of mitochondria each cell has depends on its function. Something that has to use a lot of energy, you're going to have thousands of mitochondria in each of those cells. Neurons are one of those.
Mhm.
Your heart muscle, the myocytes of your heart, have a lot of mitochondria for obvious reasons because it's beating 24/7.
Mhm.
Your brain, again, neurons, has one of the highest percentage of mitochondria per cell. Um, Your
And you're
liver,
just you're listing these long COVID symptoms, right?
yes,
Brain fog,
right,
myocarditis,
right,
liver inflammation, right?
exactly. Your liver doesn't beat, right, or think like a neuron, but it has a lot of metabolism in it, and that also requires energy. Converting one substance to another takes energy, and your liver is very energy intensive. So are your kidneys. So anything that's making a hormone, for instance, like a pancreas or your ovaries or testes, they're going to require a lot of energy to create. In fact, mitochondria are also responsible for making some steroids. They make usually single molecule carbon molecules. Single, yeah,
Single
think
carbon
of them.
molecules.
Yes, didn't sound right when I said it. But yeah, it's obviously going to affect things that have a lot of mitochondria. I mean,
And do you see this? Like, I know that we see it when we run a post-COVID lab set because we have a standard post-COVID lab set. I'm sure you do too. And that's what we're seeing. We can see the drop in glutathione. We can see stress on the liver. We can see stress on the kidneys. We can see the inflammatory factors go really high. We can see the immune activation from the inflammatory cycle, especially in the lymphocytes. All of those things that Dr. Groysman is mentioning when we run the post-COVID lab set are the things that pop on these labs all the time. And of course, there's not like a conventional direct lab for mitofunction, but you can see all of the evidence swirling around it from all of these energy intensive organs that struggle post-COVID.
Yeah, so a lot of the symptoms that we see that are related to activity, whether it's brain or physical activity, and that includes muscles and heart and um, your liver, obviously, and your brain and nerves in general. So for the mitochondrial mechanism aspect of it, you're going to see these organs malfunction or not act right. I don't know how many of our listeners have issues with alcohol metabolism, not being able to tolerate even half a glass of champagne. This is since long COVID. Um, I can't even have a half a glass of champagne um, without feeling the. I mean, it feels like I've you know had a couple of shots of whiskey,
Right.
and just it's not metabolized. So for several years, I haven't been able to drink anything. But I think it's a liver problem. I think it's not breaking down the alcohol and it's staying there longer and causing problems.
Yep.
The brain fog again, it comes from the huge energy requirement that your brain needs, especially in the prefrontal and frontal cortex. To do the high executive functions. That's what brain fog is you lose those executive functions, being able to make decisions, being able to choose a word that you want to say, right? Being able to concentrate, memory issues, especially short-term memory. All that's from from mitochondrial dysfunction.
And the interesting thing about that is we have been using fluvoxamine with a fair amount of success for long COVID brain fog. And when we looked into those mechanisms of action, certain SSRIs just have just enough of an anti-inflammatory component to them that actually can push, mitochondrial function a little bit that makes them useful tools when you wouldn't necessarily think so. What do you use for brain fog in your clinic? Like what is your number one? I mean, we sort of, when we look at long COVID, we're like, what's your big presenting symptom? And we try to sort of target there for quality of
Sure.
life and stuff while we build. How do you, I'm asking you more than one question at once. What do you use for brain fog? And then how do you prioritize which systems you're supporting first?
So, I mean, I still start with the basics.
Mhm.
Okay. If somebody needs an urgent, for instance, ability to go to an event or something, I usually recommend a very short stimulant use because you're not going to get their mitochondria back in time. Like if it's a week or two away. But if I have time, I will still start with the antioxidants first and then work on the mitophagy. Now, yes, I will include things like low dose naltrexone, which help with neuroinflammation. Really haven't used fluvoxamine that much, um, but I've used guanfacine in the past
Hmm, that's
um,
interesting.
as help for brain fog. Um, but
And just as mitochondrial function improves, of course, we have more energy to spend on making the dopamine that lets us focus, and more energy to spend on the neurotransmitters. So clarity definitely will come. Choline is super important for neuron transmission, and that can also help with the brain fog as well. So, but interesting that yeah, stimulant use. How many of your long COVID patients do you think you go to stimulants with?
very few. Only if somebody has to go to a wedding or they have to be able to take a test, something that can't wait.
Mhm.
I prefer not to. I prefer not to use stimulants because it's basically like overclocking the computer and you're driving those mitochondria harder and it potentially could cause damage, but short-term use is relatively safe.
Right.
So I mean, very few, like I said, it's if they have an event coming up or a trip or something and they can't wait. Um,
So I'm just curious about your take on this too. So, we probably all know by now the study that came out that showed that metformin was, protective against long COVID, even more protective against long COVID than something like Paxlovid that sort of has a little bit more dubious evidence for anything had to do with protecting of long COVID. You think that's directly because the protective effect on the mitochondria, or what do you think is going on there?
yeah, it's a metabolic um, modulator, and it works through mitophagy and biogenesis. So, but because it is a strong agent, like I said, I prefer not to use metformin off the top unless somebody's already on it or has tried it and has proven um,
No, I'm
not to have
talking
a
about
problem.
during acute infection. I'm not talking about
Oh,
post
okay, okay,
during
yes,
acute
okay,
infective preventatively, right? Because there's a few
yes,
things we know that when we
yes,
get COVID, we can do to prevent infection. And one of those things is metformin.
yes. It's one of the few things that's been shown to help about 41% reduction
Yep.
of risk of long COVID. The percent sounds like a lot, but when you look at the actual data, it's not as much as as you think, but it's still better than nothing.
Oh yeah, it's better than anything else so far that we really have that has like solid evidence behind it to prevent long COVID. We've been talking a lot today about how to treat long COVID, and particularly with respect to the mitochondria. But in my opinion, there's a lot more work that needs to be done on what can we do. During. I mean, number one prevention is don't get COVID, right?
Right. That's the number one thing. Yeah, try to
Number
avoid getting
yes,
COVID. And there's
yes,
reasonable steps you can take
right.
to avoid COVID, especially when you're in large crowded areas, especially when you're indoors.
Hmm. Yes,
So
wear a mask. We also like the some of the data and evidence behind Prophy nasal spray or some of the other preventative
yes,
nasal sprays to help with long COVID. Of course, staying up to date on the latest COVID vaccination, if you can tolerate them, can also give you some protection. So not getting long COVID is the first rule. And then while you have COVID, the things that we know that you can do to actually prevent getting long COVID, they're really very few. I mean, like you would think 5 years into this, we would have more things to do to stop us from getting long COVID. But
well,
all we
we
basically
actually
have,
do. We actually do. I'm going to show you a quick study here that was just released a few months ago. Um,
we
here,
know we have radical rest and we
yeah,
know we have metformin.
yeah. Let me show it to you.
Sure,
Let me see how to share a screen. Hold on. Share. Give me 1 second. I hope you can see it.
it's coming. There it is. Yep. Oh, as a
Okay.
last name. Yep.
So it
Hmm.
is a antihistamine nasal spray. It tastes god awful. Um, But this study looked at three three times a day dosing, and it
Hmm.
is available over the counter. Again, I'm not recommending it because I can't do that since this is a public forum, but you're welcome to read that study. And it was just released in September this year. And what it showed was a 71% decrease of risk for getting COVID. So basically, if you do this plus mask,
Hmm.
I mean, the chances of getting COVID are fairly low. I like the the prophylactic sprays, the barrier ones, like
Hmm.
ones with xylitol and stuff. But I think this is better. Um,
Well, we have a lot of people in our community that also layer. So, and
yeah,
if you're
and that's fine.
layering, you would do the azelastine first because it's going to need to penetrate your tissues to have antihistamine effect,
Right,
and then you could put the barrier spray over it.
right.
Um,
And this is available both over the counter and it's available by prescription if you want to have the insurance company pay for it.
yep.
But they're the same dose and the same concentration. So I don't really understand that because normally the over the counter ones have less strength
Hmm.
or less percentage, but not this one.
Hmm.
So this is another possibility for prevention. Of course, yes, the more times you get COVID, the more risk you have for long COVID. Even if you got through the first few fine. Um, but
And
but yeah,
maybe part of that is that accumulated mito damage, right? If you haven't basically, to use your analogy, cleared out all of your cells, dirty garbage holders, and then you get COVID again, and then you pile more garbage on top of that, then it's likely to be more damaging the second time around. So all the ones that didn't get it the first time, all your mitochondria that didn't get piled up the first time,
right.
another
But it
percentage
is
of them will.
treatable. It is
Yes.
treatable. So this is not permanent mitochondrial damage. This is not forever mitochondrial
Right.
damage. It is treatable. What I'm going to tell you is it takes a long time. This is the long game, okay? This is the tortoise, not the hare. You really need to stick with it, even if you don't see improvement for months. And I've had patients on for longer than a year before they started seeing major improvements. So really, it's not a weekend or a week and you don't feel better and you quit. That's not going to work. You really need to stick with the therapy, even if it doesn't seem like it's doing anything. It is. It's just a very slow process and it has to reverse all the damage. And if you have 3 or 4 years or 5 years of damage, it's going to take a long time. It's not going to happen over a month or two. It
And
just takes a long
sometimes
time.
you can see improvement in laboratory markers before you actually can feel the improvement or see it externally in symptoms. So a lot of times things are healing and repairing, but you can't necessarily tell until they actually start working with some level of proficiency again.
Right. And I have some patients, who quit after 3 months. And the thing is you may not get there in 3 months. And some of these supplements, yeah, they're a little expensive. I try to budget them and try to pick ones that are not that expensive if I can, or if there's a budget constraint. But obviously, taking supplements or a bunch of supplements for multiple months adds up. But it
Mhm.
does work. It just takes time. And if you can hang in there, it does the work and it actually does get better. I don't know if you want to jump to questions or not, because
Yeah.
I'm seeing things popping up. I'm not sure.
Yes. So the first question that I'm seeing here is when you were referring to stimulants, were you also talking about nicotine patches? Or is the nicotine patches something different than you were talking about when you talk
Well,
about stimulants?
nicotine patch or nicotine, I guess, is a sympathetic stimulant. So it stimulates your brain and stimulates your heart. However, because the patch is kind of a slow releaser of nicotine and there's no peaks or valleys, it doesn't typically cause as much tachycardia. um, like a cigarette or nicotine gum would. But yes, technically, nicotine is a stimulant, and it does improve focus and concentration. I mean, some people use it for tests and stuff, but if you have mitochondrial damage, it's something to use cautiously because in the beginning it may help with mitochondrial function, by the way, but if you continue to use it, then it can cause increased oxidative stress. So, but yes, to answer your question, nicotine is a stimulant.
And I think I can give you my take on this next one, and then you can tell me if there's anything to add. But if something's taking a year to show improvement, how can we know if it's the therapy that caused the improvement or just the body healing over time? And I would say for at least for us in our clinics, we're not going a year without, measuring lab function. We're not going a year without looking. We don't just have one target symptom. We usually have multiple target symptoms, and it's not like you don't get any improvement in a year. It's just your improvement is very slow and gradual and never as fast as we hope it would be. We hope that, like, in 3 months, we're back out running our marathons, when really in 3 months, we actually might be able to, tie our shoes and get dressed and go to the grocery store. so, so for us, we would have additional laboratory markers that we would be following as well as that symptomatic picture. Do you have anything to add to that, Dr. Groysman?
Yes. So if the mitochondria would kind of repair on their own, you would see improvements over the last 3 or 4 years that you've had long COVID. And the fact that you didn't, it's not like your body is all of a sudden going to be able to heal these mitochondria on its own. It's not that it's not trying, it's just that these mechanisms are severely damaged. And the system just needs some help to get it going. And because it's so fragile, like I said, if you try to rush it or kind of hit it hard, you'll be sorry. You'll have a post-exertional malaise crash, and you'll cause more oxidative stress, and you'll have more mitochondrial damage, and you'll have more work to do, longer time to fix. So I always try to get my patients to avoid crashes as much as possible. But yes, so that's how you know. And yes, like Kara said, you monitor labs over time, and you see what's going on. I mean, usually it doesn't take a full year for people to see some improvement, but it certainly can take longer than 3 months to
I
start
would say it,
noticing
it
anything.
usually takes at least a year or more to get back to like what previous baseline was if you got a really serious case of long COVID.
And it again, it depends on how much mitochondrial damage you've accumulated. Like I said, if you've had this for 4 or 5 years and you have a lot of cellular damage and mitochondrial damage, it's going to take longer. And if you have COVID for 3 months or long COVID for 3 months, it's not going to be as long. So it's really undoing all the damage, but it has to be done very slowly and gently and carefully, not to cause crashes or worsening of symptoms. So that's how you know that it's the therapy that's helping and not just time, because you already had all that time
Right.
and it hasn't been getting better. Otherwise, you wouldn't be here.
Exactly.
Um,
Do you have any thoughts on peptides, such as the recently FDA approved SS31?
yes, I've looked at SS31. I don't use peptides as often because they're difficult to source. But I do like SS31. I do think it can help with certain mitochondrial improvement as an adjunct. I wouldn't use it as a sole. So a lot of things I do is I combine things in a specific way to accomplish something. It's not the one magic pill that's going to fix it. And it's not taking one thing at a time that's going to fix it. It's the combination of things that are kind of doing multiple things. It's like the
That's the art of medicine.
Yes, that's the art of medicine. It's kind of like NASCAR when they change the tires. It's not one guy going to each tire, changing the tire. You have the whole team come in and they do it very, very quickly and efficiently. That's kind of what you have to do.
Okay. I can start with this one. Would you be able to share again some of the labs that indicate damage? And so I know since we trend labs pretty heavily in our clinic, we can see just in your basic comprehensive metabolic panel, you can see your liver stress and your kidney stress. We also run, inflammatory markers like a SED rate or a CRP or a D dimer. Because COVID is, a coagulatory disease, we also will run your coags and see what's going on there. Now, specific to mito function, like I said, you can see the drops in the B12 and the serum B12 and serum folate levels. You can see the drops in the plasma glutathione levels that would indicate that something's going on, something's sucking basically those nutrients away, or that you're not absorbing them. But there's not really one test that specifically looks at mitochondrial function, unless you're talking about like you can do an organic acids test, but that can also be less specific. Now, the gold standard for testing mitochondrial function is actually a muscle biopsy. But of course, who wants to go in and get a muscle biopsy periodically to check their function? And so we have had some success using this. It's a buccal swab that has an 84% correlation with muscle biopsy. And they actually do take a lot of insurance plans. So it's not a test that you necessarily have to pay out of pocket for. And this test actually, it checks the number of mitochondria. So it's sort of looking at whether or not you have mitochondrial replication or you have a lot of oxidative stress because you have too many. And it looks at those four pumps we were talking about in that electron transport chain that are making those gradients. And so we have used this as well as, a marker to periodically assess mito function. What other markers am I forgetting, Dr. Groysman?
I like the O test a lot. I think it gives you a lot of information, even if it's not super specific for mitochondria, but it can show breakdowns in the Krebs cycle.
Mhm,
It could show issues with fatty oxidation, beta oxidation,
mhm,
and you can tweak or modify the treatment based on the results. I like lactate and pyruvate.
mhm.
Um, it's not often going to be high. I found it to be low in people with hypometabolism.
Mhm.
So everything is slowed down. So the mitochondria are not producing the lactate because they're not working. Um,
Right. That makes sense. Okay, for prevention, how does azelastine compare to prophy, or should we use both in a layered approach? And so that's not really apples to apples. Azelastine as an antihistamine and prophy as a barrier spray with an antimicrobial they're not really doing the same thing, which is why personally I like the layered approach when you're talking about two different mechanisms. It's not like you're putting two barriers there or you're putting two antihistamines on board. Now, the difference in data with azelastine is that was a human trial, and Prophy only has mouse trials. And so, if you're looking at, Prophy had a 99% blockage rate, but that was in mice, and azelastine had a 71% in humans. And so, if you had to just pick one, maybe you might go with the azelastine, depending on if you tolerate the taste, and yes, it's safe to use every day. I mean, it's just an antihistamine. But for me, probably I really like Prophy as a barrier too. So again, I would do the azelastine first, wait a little while, and then do the Prophy personally. But that's what I would do personally, not what I'm telling you to do. What do you what do you think, Dr. Groisman?
I mean, I think there's multiple ways to approach this. I don't think there's really any right or wrong way. It's whatever you can tolerate and get your hands on.
Right, exactly. Whatever you
Anything is
have in
better
your
than
cabinet
nothing.
too is the best thing, right? Whatever you will spray is the best thing. Um, is all this information in the book? Is everything we're talking about tonight going to be found in your book?
Most of the stuff that we're talking about is going to be in the volume 3 book. Yes, I don't know for sure if everything, because I don't remember everything we've discussed. But I believe most of it will be in there.
Yeah, a lot of it will. There's a lot of overlap in even just when we hang out and talk of the different ways that we things that come up. And like just so you guys know, we didn't really plan this tonight at all. We just sort of said, hey, let's go talk about
Pretty
mitochondria
much.
together. So we have a lot of synergy in the way that we view things. So yeah, a lot of this will be in the book, and step by step. I know in the book there's like a list of labs you can ask your healthcare
Yes.
providers to run, and there's list of different things that you can kind of pick and choose to
Yeah,
help.
I list antioxidants that are better for certain organs, and that's part of how I decide of what I want to use for each person. So you can certainly do that yourselves. Um, One of the most important things I want to mention is that I am mechanism centric. I don't really treat symptoms. Okay. I know Kara's mentioned a few things like brain fog and stuff. And if nothing else, if what I'm doing is not working, yes, I will kind of go to the backup plan and treat the symptoms individually. But what I find is if you just use the symptoms to help diagnose which mechanisms are involved, and there's six mechanisms that I work with, and you can have all six, or you can have just one. And by focusing on the mechanisms, I can peel off the layer one layer at a time um, to get you better. So basically, I'm not trying to treat your tachycardia or your brain fog or your anxiety. I'm treating the mechanism that's causing all that. And initially when I started, I used to be symptom centric. I went after the symptoms, I chased them, I did what everybody else was doing, and then I said, this doesn't make sense. And
Using the symptoms as, again, like as something to track for relative improvement is different
yes,
than just going after the symptom.
correct.
So if I can say, okay, every day I forget to close the cabinet doors because I have brain fog. And I can sort of track that. And every day, I never close these cabinet doors, so 5 or 6 times I walk in the kitchen and the cabinet doors are open and I'm like, oh. And then, I start working on the underlying causes. And now I'm noticing that, oh, my cabinet doors are closed about half the time when I go back into the kitchen. That's using a
Exactly.
symptom to sort of mark improvement. You're not targeting the closet door, the cabinet door closing. You're targeting what's causing the brain fog, if that makes
Right.
sense.
Right. And I use the symptoms to kind of sort through the mechanisms that are involved. And like I said, some people have one, some people have six, even though you all had the same COVID, but the different variants attack different organs and cells. And we have these little infirmities that don't bother us normally in life, okay? But they put you at higher risk for more damage because there's that little infirmity there. You would have never known about it for the rest of your life if you didn't have COVID. But COVID exploits that. And, some people have more damage than others. I'm actually surprised at how much difference there is in the amount of damage between people.
Well, and 20 to 30% of people come out with long COVID. And what about the other 70 to 80% of people who don't? What's the difference in their metabolism versus someone who gets, knocked on their butt for 5 years? It's all a lot of science that we're unraveling. And it's an intriguing mystery.
It is. And I do think part of that is that their systems are just robust enough that
Mhm.
even though there's damage, they're able to recover.
Yep.
And the rest of us can't.
Yep.
Um, and that's genetic diversity that's out there. It's not necessarily like a genetic defect or anything. It's just a
Mhm.
normal genetic diversity that's present in all our
Yep.
genes. Um,
Polymorphisms instead of
exactly.
mutations.
Um, and it's a good
So,
thing that exists because it would be horrible if 100% of the population got something.
right.
Um,
That would be bad. Okay, can you take berberine instead of metformin? I'm from New Zealand and long COVID isn't recognized. No doctors are treating, and I know of, so it would be really hard for me to get metformin prescribed.
so they work differently, even though berberine can be used to lower blood sugar, just like metformin can, but they have slightly different ways of causing mitophagy. So technically, you could use berberine for mitophagy, yes.
Yeah, and you could use it during acute COVID instead of metformin if you didn't have access to metformin. The only thing you do have to remember is berberine is heavily metabolized by the liver, and so you want to make sure you have a lot of liver supports on board if you're going to use berberine for any extended period of time, or if COVID is already going to be stressing your liver, and you want to take the berberine to for some mitoprotective effect. You better have plenty of NAC on board, maybe some milk thistle and some other things to be protective of your liver while it's also processing that berberine. What kind of doctor can test for mitochondrial disease, and what tests do we need to ask for? So I think this goes back to what Dr. Groysman was saying about a mitochondrial disease or disorder and mitochondrial dysfunction. So you want to take that one again?
So I wouldn't start with labs for mitochondria, mainly because, like Kara said, there's not 100% specific way, except maybe a biopsy, um, to be able to diagnose it. And you would start with figuring out if you have mitochondrial dysfunction.
Mhm.
That's where I would start, before. But any doctor, any MD, DO, nurse practitioner can technically order any test that's in the catalog.
Let's be real. They're not going to do it. If you want to test for your for mitochondrial dysfunction, do not go to your PCP
But
and
they
say, test me
can.
for mitochondrial dysfunction.
Yes,
They could, but they're not going to. So look for a functional medicine doctor, an integrative medicine doctor, or a long COVID specialist if you really want somebody to like look at for mitochondrial dysfunction. You're not asking to check for mitochondrial disease unless you're really seriously thinking you have a genetic defect from birth that affects
you
all
would
your
know.
mitochondria.
You would
That
know
yeah,
if you had a mitochondrial defect.
that's different
Um,
than the mitochondrial dysfunction that Dr. Groysman said that's treatable and temporary. So you can't really go to you can't really go to the traditional metabolic or genetic mito doctors and be like, test me for mito dysfunction from long
they won't
COVID.
do it. They won't do it.
No. Well, and they might tell you what one of my good friends told me, who's a geneticist in Colorado, who does metabolic disorders. He said, Kara, if they can walk in here and breathe on their own, stop bringing them to me.
That's right.
Because he has an 18-month waiting list for people with very severe mitochondrial
Yes.
disease. And so people with mitochondrial dysfunction, even though it's horribly impacted for our lives, he does not have space in his schedule for somebody who doesn't have a problem with every single mitochondria in their body. And so that's where you want to look for that integrative doctor. You want to look for that functional med doctor. You want to go see Dr. Groisman. You can come to Lighthouse clinics, depending on which state you're in. Get somebody like that to run some of these tests and look for the mito dysfunction and help you work through the oxidative stress and the energy deficit.
But it's mostly history based, believe it or not. You can figure out if you have mitochondrial dysfunction mostly from history. Now, if you want to know how much mitochondrial dysfunction, labs are useful there. And of course, if you're not sure, they can be used to confirm. But if your labs come back normal, that doesn't necessarily mean that you don't have mitochondrial dysfunction, okay? Um,
I mean, I would be really surprised that your mito swab came back normal. We've trended serial mito swabs, and it's actually pretty legit in terms of picking up on what's going on if you can get the doctor that will order the mito swab for you. Um, would some of these approaches help with folks who are experiencing chronic Lyme or non-COVID post-viral chronic fatigue? Do you believe mitochondrial damage is the root cause of chronic fatigue? I'll let you go first.
well, okay. I mean, chronic fatigue I mean, if we're talking about chronic fatigue syndrome, um, um, if that's what we're talking about, mitochondria can be involved there as a primary mechanism. Um, there are studies showing some of the proteins for Epstein-Barr and Teravirus, for instance, that can damage mitochondria in a similar way, but they're different proteins and they work completely differently from what COVID does. Um, Lyme is kind of a whole different story. Lyme is caused by the spirochete bacteria that are kind of parasitic. So, they may start out in your blood, but then they get into your cells. And if you have untreated Lyme or if you don't know you had Lyme, um, I'm not really sure how to answer that question.
let me give that one a shot. Okay. So in a short answer, yes, mitochondria damage or dysfunction can be the root of chronic fatigue, or like Dr. Groysman said, EBV is a big cause. But when we're talking about Lyme or EBV or mycoplasma or post-inflammatory conditions from strep, what it really boils down to is it's not the pathogen. And the reason why I say it's not the pathogen is because if it were the pathogen, every single person who got bit by a tick that had Lyme or a Lyme co-infection in it would get sick with chronic Lyme or would get sick with co-infections. And I'm from Arkansas originally, for those of you who don't know. And in Arkansas, ticks are just a way of life. Okay. And when I was a little kid, I'd go outside, I'd play in the fields, I'd come in, and mom would say it's dinner time, and would come in, would go in the bathroom, would pick all the ticks off of us, would throw them in the potty, would flush it down, we wash our hands, and we go eat dinner at the table. I've had thousands of tick bites in my life, and I've never once had Lyme or Ehrlichia or anaplasmosis or Babesia or Bartonella or anything. Now, my grandfather got Rocky Mountain spotted fever. He had antibiotics for a few weeks and he was fine. My sister got Lyme, but she had antibiotics for a few weeks and she was fine. But then when my kids who have complex chronic illnesses and certain dispositions, including mitochondrial and a lot of immune dysregulation, when they were growing up in Arkansas, a couple of them that do have these similar kinds of problems. One of them had Bartonella, one of them had active Lyme. Why did my kids get Lyme disease and I didn't? And so that's brought me around after several years of like going with this around and around in my head. It's the immune system. If you have an imbalance in your immune system, and a lot of us who have an inflammatory propensity also have a corresponding deficiency because there's not enough mitofunction to keep both going. I can't pay enough ATP to both inflame my immune system and calm my immune system down at the same time and fight things off that come along. And so what we see with people who have stuff like chronic Lyme is today it's Lyme and tomorrow it's mycoplasma. And then all of a sudden I'm reacting to EBV and I'm in the bed with chronic fatigue. And then I have, post-infectious encephalopathy or PANS-PANDAS from strep. And it's not the pathogen. It is the immune system. And a big part of immune dysregulation often can be mitochondrial dysfunction. It can be a lack of energy into that system that keeps the pro-inflammatory and the anti-inflammatory systems in stasis. So the answer would be not all chronic fatigue is caused by mitodysfunction, but a good part of it could be, and some of it in these chronic illnesses can be mitodysfunction. Other things could be defects in your immune system, like my immune system doesn't recognize my certain toll-like receptors don't work well, so they don't recognize the EBV virus, and so I can't fight it off properly, or they don't, activate the chain properly to actually fight off that Lyme infection, and then they let it sit around and get into my collagen and eat my disc in my back out and make me feel horrible, right? And so the answer is sometimes mitochondrial dysfunction is the root of chronic fatigue.
And just one last thing about the immune system. So your immune cells are kind of unique because they require mitochondrial energy, ATP, to basically move around, which is kind of like amoebas. Some cells kind of can crawl through your tissue, which is requires energy, and some cells need energy to release their contents. Now, what's unique about white blood cells is they also need energy to remain stable. And if they don't have enough energy to remain stable, they may just release their contents willy-nilly, and that's not good either.
Right. It's all about the energy. So a lot of it does come back to mito issues and how much of my ATP dollars, my bandwidth, my banked energy, am I spending perpetuating inflammatory response, and how much of it can I spend to actually fight off things that I need to fight off, and how much of it can I spend to stop that inflammatory response. And we see that when we see the data. I don't know if you guys remember the article, but it compares actual immune suppression in COVID to people who have active AIDS. And, when you get a COVID infection, at about 3 weeks, your numbers start to go down, and then they tank at about 4 months. And then for people who recover completely, those immune numbers will start going up. And this is your lymphocyte panel, your T cells, your B cells, your natural killer cells. You can actually watch them. And in that nadir, they're at or lower than people who have active AIDS. And then if you don't get COVID again and you take really good care of yourself, at about 8 months that you recover and you have, immune function where it was, unless you got long COVID and you can't quite get there, or unless you got COVID again at 3 months and then you knocked yourself down again. And that's another reason why those cumulative infections are so damaging, is because they don't give your immune system time to recover and come back up. And so we do see like a resurgence of like a reactivation of Lyme or a reactivation of chronic EBV or other things post COVID infection, because your immune system that was keeping those things on tap in bay, or keeping your white blood cells under control, and the other things sort of at a manageable level, all of a sudden loses that capacity as it tanks in that nadir, and then comes back up.
So the only thing I'm going to say about that is I find that COVID mostly causes immune dysregulation, and
Mhm.
that could mean slight depression, but nowhere near to HIV levels. I mean, it doesn't cause you to develop the same kind of opportunistic infections that HIV does. And most people actually don't have the T cell suppression. There is some, but it's usually temporary and nowhere to the same degree.
Are
Um,
you um are you trending? Are you trending lymphocyte panels?
no, I don't look at lymphocytes.
Because we trend lymphocytes, and the research is there, especially particularly in your natural killer cells. It's different for different people. Some people actually do B cells. Some people it actually shows up in your natural killer cells. It's not the same for everybody, but it does drop you to. Now, I'm not saying it gives you all of the same opportunistic infections, because it's one component of your immune system. If you have active AIDS, usually all of your components get suppressed at once. When you have COVID infections, like for most people, it's like your B cells will drop, but you still have your natural killer cells, you still have your T cells functioning for you. Or your B cell, your natural killer cells were dropping, you still have your T cells and your B cells fighting. So it's not exactly the same as AIDS in terms of global immune suppression. But when you look at those individual markers will go down. And we knew as early as I think it was 2022, with that study with all of those graphs came out. I'm gonna find it for you. But you're right. It's not like everything crashes at once. Two things that have helped me are sertraline and LDN. Do you have thoughts about those?
Yes, I mean they're very different, obviously. Um, Citrulline um, is an amino acid. It's not a protein forming amino acid, but it comes from arginine, and it's a great nitric oxide donor. So it helps with vasodilatation, for instance, dilating your blood vessels. It's an antioxidant. It's able
They're
to.
talking about Zoloft, sertraline,
Oh, so,
Zoloft.
okay. I'm thinking of citrulline. I'm sorry.
Yeah, no, no, that's probably my accent.
Zoloft.
Zoloft.
Okay, okay.
Yeah,
So
Zoloft and
that's
LDN.
different. That's an
Yeah.
SSRI. Um, it's neutral to activating SSRI. What's the I'm sorry. What was the question? Because I got off on my tangent and I forgot what you asked.
The question was that the two things that helped them most were Zoloft and LDN. What are your thoughts about that? How do you think those are synergistically working together, or why are those the two things that helped them most with their long COVID?
Well, I don't know what it helped with, but in general, SSRI will help with not just brain increase in serotonin, but also peripheral serotonin. And there's been several studies showing that tryptophan is not being converted into serotonin. It's going down another pathway, and that could be partly why it's helping. It can help with mood, obviously, and a bit with anxiety. The LDN is a neuro. Um, it's an anti-inflammatory for specifically for nerves, but it also helps with the immune system. So it can help modulate and help control the immune system, especially if it's overactive. So remember, I said the immune system is dysregulated, which means it has wide swings. It kind of swings like a pendulum from one end to the other. If it gets too high, you have inflammation and maybe even autoimmune conditions like Sjogren's, rheumatoid arthritis, lupus. I don't know how many patients you have with that have been diagnosed with lupus since COVID. Um,
Those positive ANAs popping everywhere.
right. And then it swings the other way. Um, so it helps kind of stabilize that and modulate it back to more the middle. So low dose naltrexone helps with brain fog and fatigue for those reasons. There's some indirect help with or support for mitochondria from LTN, but without knowing what your symptoms or mechanisms are, it's impossible for me to know how it could be helping since I don't know which things it's helping with.
Right. And just a caveat about LDN, it's super dose specific for each individual person, and it's not necessarily based on age or weight or anything. It's how your individual immune system responds to the LDN. And so when we use LDN, we do a 0.5 milligram titration because some people need 2.5 milligrams, some people need 5 milligrams, some people need 0.5 milligram. You just don't know unless you sort of titrate it up to find where the sweet spot is for every person's individual immune system regulation, if that makes sense.
Yes, that makes perfect sense.
I suspect COVID recovery has something to do with personal DNA, such as MTHFR detox ability.
I don't think MTHFR really it plays a role in long COVID. Methylation does, but not due to a gene defect. The reason is that the majority of us, about 70% of us, even 75% of us, are walking around with one of our genes, either from mom or dad, that's technically defective. There's two common uh, I guess, variations. In fact, those are even more common now than the wild one, which is considered the normal one. It really isn't anymore since 70% of the population has one or the other. Even if you have both, it's really not making a huge impact on methylation. Yes, it decreases it a little bit, but really there's other problems with methylation with long COVID than MTHFR. I'm not saying to ignore it, but what I'm saying is you can't really do anything about the MTHFR anyway, since it's a gene. If you're going to treat methylation, treat the methylation. If you have a methylation problem,
So MTHFR, like Dr. Groysman said, it's a really common polymorphism, depending on which variation that you have. But you actually can treat it because you can jump that enzyme by taking, just taking methylfolate. And so taking methylfolate sort of takes your MTHFR enzyme out of the picture because
right? That's my
methylfolate
whole point. Is just
yeah, is
treat
the
it.
end product. Yeah. So if you're having problems with your methylation, you can take methylfolate and that's going to actually fix that. Now, if you have a problem with methylation and you can't conjugate methylfolate, that's going to affect your mito function. And if that's affecting your mito function already, it's probably not pulling it all the way down, like Dr. Groysman said. 60 to 70% of people are walking around with that. But then you take the added stress on top of it of COVID insult, and you may need more extra of those B vitamins or cofactors to get that in that whole methylation system to get you back to where you want to be. I
My,
found a
my point
diagram.
is don't test for the MTHFR gene because it doesn't change anything. Just assume
Right.
you have it and just treat it.
Just
It's
take your
expen-
methylfolate.
it's
Take your
expensive
methylfolate.
test and the medicine is dirt cheap. So why are you wasting money on a test that's not going to really change what you do?
That's true. Unless you get it from LabCorp and your insurance pays for it.
Well, okay, if your insurance pays for it, that's a different story. That's
Yeah.
fine.
I was just going to share this here. So this is a study, and I'll click on the study in a second. That's actually not the study link. The study link's down here. And this is actually showing what I was talking about. It compares the different T cells and your CD4, CD8 ratio and your natural killer
Yes.
cells and your B cells. Um, Patients who have COVID and patients who are AIDS patients. And so everything doesn't crash at once. But, for some people, their natural killer cells do get down to the level of active age patients. For some people, it hits their CD4, which is those are their helper, the T cells that call in and help fight off infection. It's really hard on CD8. Those are your
Yes.
anti-inflammatory T cells. And so you can see how really low the anti-inflammatory T cells drop. And that's what makes this inflammation ratio so high. This is saying I've got way more cells calling for attack than I do calling to turn off that inflammation. And then for some people, it will drop their B cells. And so when we trend these lymphocyte panels, it's very individual. And Dr. Groysman is right. You don't see it like all drop at once. But for some people, you get some B cell vulnerability. For some people, you get natural killer cell vulnerability. Some people, you get this huge inflammatory ratio. And when they looked at the study, these little charts right here, the 12 is 12 weeks post-infection, the red is 16 weeks post-infection, and the yellow is 24 weeks post-infection. So you can see how these cells would, start to drop, and then they would get, down. Or actually down regulate. This is down regulation. So you would see it start to
Yes.
drop, the down regulation grow. At about 4 months, it like peaks, and then at 24 weeks or 6 months past, it drops back down to normal. This is in like COVID patients that don't have long COVID that recover healthily. And so everybody who gets COVID does experience to some degree some level of immune dysregulation like this. It's just a matter of how resilient your body is, how well it can handle the 4 month nadir, and how quickly can it get you back up, to at your 6 month mark or at your 8 month mark, can it get you back up to where you were? And so this study is one of the reasons why we started trending the lymphocytes, and I'll show you guys the actual name of the study in case you're interested. And then it was the long-term perturbation of the peripheral immune system months after COVID infection. And
I
you can,
read this study.
yeah, yeah.
Um,
And so we started actually looking at this in clinic on real patients, and we were able to see the patterns that the study elucidated in actual real patients in clinic. And if I ever had my act together, we would pull all that data and publish too. But my act left a long time ago, so I don't know what's going on with it. But um, it's definitely the immune dysregulation is one of the
right.
key features of long COVID.
Right. I guess my point um with COVID is it doesn't directly target immune cells. It's an indirect effect on the cells due
Mhm,
to the increased reactive oxygen species that are created,
mhm.
that and the mitochondrial damage that also causes the instability in the immune system, plus the dysautonomia. Sympathetic overdrive will cause immune
Yes.
overactivity. Um,
Mhm,
People with HIV, every single person, their CD4s are going to drop. Why? Because HIV enters the CD4 cells, it inserts itself into the genome of those CD4 cells, and it's DNA, so it's permanently there.
mhm.
Um, COVID doesn't do that. It's more of a reactive
We hope
immune
it doesn't chromosomally integrate.
well, okay.
CMV does. Did you know CMV does?
Well, yes, CMV is a
Yeah.
herpes family virus, just like
Mhm.
EBV is, just like varicella zoster is, just like all the herpes family viruses. I mean, the HH6, 7, 8, all those. Yeah,
I've
those are
never
herpes
seen
family.
HHV6 chromosomally integrate.
No, I'm not saying chromosomally integrate. I'm just saying it becomes part of our kind of landscape.
Right.
Herpes
Chronic
doesn't.
infections. Yeah.
So herpes is weird. It doesn't really integrate. That's not its main mechanism,
Right.
but it persists intracellularly. What I was trying to say is that the because HIV is a retrovirus,
Hmm.
it inserts its DNA into our genome, so it's permanently there, and it specifically targets CD4 cells.
Right. Right. Yeah, no,
Um,
I totally agree. I think I mean, honestly, I do think a lot of it's secondary to mitobandwidth.
um,
It's that inflammatory response that uses up a lot of the mitobandwidth coupled with the mitochondrial damage that causes the immune dysregulation. And then once you can get your mitochondria back up and running, then your
right,
cells recover.
right. So your immune system improves and your immune function improves and your energy improves. But again, all the immune system, I think, is early compared to the other functions of the mitochondria. I find um, immune system improvement earlier than, like, for instance, being able to do cognitive or physical tasks.
Yeah,
Um,
that makes sense because the brain's more energy dependent than the immune system, right? So like it would
yeah,
sort of come back online as you had ATP to run it. Um,
I mean, the most important thing you could do besides antioxidants is just avoid the crashes.
right,
Normally, exercise is a good thing, and if you can tolerate, great. But if you're crashing every single time you're exercising and you're out for a few days, you're laying in bed, it's doing damage. So my
right.
advice is to avoid crashes as much as possible. Now, the amount of stuff you're going to be able to do is going to increase over time. But if you try to push through it, you're going to be sorry because not only are you going to crash, but you're also causing additional oxidative damage because that's what exercise does. It causes mitophagy, significant, but it's a double-edged sword. It also causes significant oxidative stress. So maybe tone down the exercise for right now. Some people can't exercise, some people can't do much. But my point is just to try to avoid crashing, especially in the beginning, and let your body heal, because that's what it needs to heal.
So one last question. I know someone who had OCD that was controlled after they got a COVID infection, their intrusive thoughts have dramatically increased for months now. What would cause this, and is there something they can try?
Hmm. I mean, OCD. I mean, there's many different psychological conditions that can get worse. During long COVID, depression, anxiety. Some people have, uh, depersonalization. So it's basically certain areas of the brain, I mean, are affected both on blood flow and mitochondrial function. Um, it can
Look
cause,
up look up pandas and try steroid burst. COVID can be a pants trigger too. And so that basically is an autoinflammatory attack on of your own immune system on your brain. And so a lot of times we see with these, the neuroinflammatory stuff that Dr. Groysman was talking about, post COVID, you can, trigger your own, basically your own immune system gets triggered to increase that microglial activation and increase your own, self attack. And so if you're seeing someone who had OCD and they get in a COVID infection and now they've got intrusive thoughts and all of that, one way to sort of test that is to try, go to their doctor, medical provider, and ask them for a 5-day steroid burst. And if all of a sudden their intrusive thoughts are a lot better while they're on steroids, you sort of have a ping for, okay, I've got neurological inflammation that's driving that OCD or those intrusive thoughts.
so what's interesting about the brain is because the blood-brain barrier, it has its own immune system. As you mentioned, microglia are the main parts of it. So it kind of has a separate immune system from the rest of the body, which
Yep.
means that it can activate and do things differently, separate from what else is going on in your body, which creates interesting scenarios.
Hmm. That's a good way to put it. That's a very adept way to explain it. I'm going to steal that.
Sure, go ahead.
Thanks. Well, I really appreciate it. We're sort of out of time now, but thank you so much for being with us today and sharing all of your expertise. And if you guys want more of Dr. Groisman's expertise, you can certainly check out his books, the Long COVID Handbooks. Are all five out now?
There's actually seven. Since
Seven.
since we talked, I added endothelial dysfunction, microclots, and hormone imbalance. What I've been finding is thyroid deficiency
Yep.
due to effect on the hypothalamus and pituitary, and I've also found sex hormones, basically testosterone, estrogen, progesterone issues, and I found cortisol issues. So I decided to include that in the series. So now it's 7 volumes. One is the overall, but volume through to seven will be all of the mechanisms. Right now, I have one, two, three, four, and seven out. The reason I did seven is because I was studying hormones a lot, and I decided to go ahead and just put it down. Yes, volume seven is hormones, um, hormone imbalance. It's not, so I actually pulled it from Amazon. I wanted to make a couple of corrections before putting it back out. So it will be back out soon, but I'm working on five now, which is MCAS and histamine intolerance, and hopefully before the end of the year, all of them will be out. But with clinic time and everything, and um, it's hard to really.
Hey,
Uh,
you're doing great. Yeah, you have an active clinic. You have almost like two parallel practices, and you
yeah,
have, and you're writing books.
I'm
Kudos.
I'm writing it at night. I wake up sometimes 3 in the morning. I have an idea and I write something down, or I'm writing it on the weekends, which kind of really hampers family life. But it is what it is. I really want to finish this series out. I actually have something else I'm working on kind of the side. My extra project. It's a 3 volume encyclopedia,
Oh,
and this one it breaks down every single mechanism um, in very specific details. Why I think it's a primary or not. Um, the second one is symptoms, and it covers more than 230 symptoms of long COVID. And the last one is treatments, and it
interesting.
covers basically from A to Z every treatment out there and kind of where it's applicable.
Well, that's great. I can't wait to
But
read it. I can't wait to
but
have a
that's
look.
uh that's a lofty project.
Oh yeah,
Uh,
absolutely.
yeah. So I kind of have an outline of what I want to do. It's just I need to find a couple of minutes. Um,
I hear you. Well, thanks so much again, and thank you all for being with us today. And definitely check the books out. And I'm sure we'll do some more of these because I really enjoy going back and forth with you and discussing all of the nuances. It's really fun to have somebody geek out with me on this stuff.